Hi, everybody. Good afternoon. If I had known I had to follow future Mars sequencing talk, I don't know if I would have agreed. That was fantastic, Sarah, but it's great to be here. Thank you to Oxford Nanopore for the invitation. I'm going to be talking about some work at the Wadsworth Center, and I'm just fortunate to be able to provide this to you. I'm representing the work of many scientists at Wadsworth Center, and I'll try to point out those with pictures throughout the talk. But if you're not familiar, Wadsworth Center, New York State Department of Health's public health laboratory, we're the largest state public health laboratory in the country. We have 5 sites currently, about 750 staff, 150 doctoral level scientists, a good amount of space and BSL-3 space. We have a lot of both public health laboratories as well as research laboratories, so it's a nice mix of academic, clinical, and public health work. And we're very excited someday in the future, it might be after I retire, but there will have a new building in 2030. That's quite a big proposition for New York State. And I just wanted to show you, in case you didn't know where Albany, New York was. You can see the little star there. We're very close to a lot of New England, and New York is quite big, not as big as Texas. But we serve as a regional lab as well for a lot of the Northeast region, both for the AR Lab Network that some of you may have heard about this morning, as well as the PulseNet programs. And I just also wanted to note that we have a large focus on research as well as public health and regulation. We're a regulatory body in New York State, so that allows us have the framework in terms of developing and validating new assays. We have CLEP in New York, so we are CLIA exempt, but that has allowed us to be able to both oversee testing on New York State patients as well as the testing in-house. And we're really fortunate to have our own in-house LIMS that allows us to do a lot of that tracking and recording of all of the testing that occurs. Okay, so what do public health laboratories do? I just pointed out a few of the things. So we rapidly determine the source of outbreaks. We do reference testing, so anytime there's a bacterial sample in New York that a clinical lab can't determine or needs to do additional testing, we provide that. We contribute to national surveillance, and some of the examples are listed here. We also, as I've mentioned, do assay development, and we're always thinking about emerging infectious diseases, and so some of those are there. And I'm going to talk a little bit about the antimicrobial resistance aspect of that we do in my laboratory. And so when we started to think about nanopore sequencing, we wanted to really think about ways we could do impactful work for public health, taking advantage of everything that nanopore sequencing provides. And so the 3 areas I'm going to talk to you about today is that AR gene detection and plasmid analysis with long-read NGS sequencing. I'm also going to talk to you about our bacterial species identification work that we do for our reference testing using targeted NGS sequencing. And then finally, something that's really exciting to a lot of us, I'm going to talk about some targeted NGS sequencing work that we do for respiratory specimens for TB cases. Okay, so, and this has come up a few times at the meeting already, but in terms of those antibiotic or antimicrobial resistance detections, so we're interested in the nanopore sequencing to characterize mobile genetic elements carrying novel or uncommon resistance genes. We're looking for that genomic context of AR genes. Is it on a plasmid? Is it in the chromosome? Are there multiple plasmids present? And we're trying to understand also about plasmid transfer events associated with healthcare facility investigations. And like I said, we've got a great team of bioinformaticians, library prep specialists, program folks. We've had fellows, so a lot of great work happening on these projects. And so just to visually show you, when we started to think about needing nanopore sequencing for the plasmid analysis, we were doing, and we do a lot of Illumina, MiSeq, or NextSeq sequencing, but when we would start to understand where is that gene, is this important, what size is the plasmid, we couldn't tell any of that. And so using the long-read analysis and combining the methods for that analysis has been really helpful to understand the chromosome, the plasmids, how many genes are present. And so the first example I want to tell you about was a carbapenem-resistant Pseudomonas aeruginosa, 65-year-old with a foot wound in Rhode Island. In our regional role, we work with the Rhode Island Public Health Lab. We received a sample, and it was a carbapenemase-producing organism, but none of the typical genes were present. So we did our normal confirmatory work, as well as whole genome sequencing, and we detected the BLA-SIM1 gene. We used Nanopore sequencing to understand the context and the plasmids that were present. And we were able to publish this. It turned out it was the first detection of this in the United States. And the work led to us being able to bring on a PCR for that gene, so we could do some screening and other work, as well as just furthering the understanding and having others be aware that this could be a source of novel antimicrobial resistance in the future. The second example was a very interesting case investigation that we worked on with the Maine Public Health Lab. They had some KPC-producing bacteria at 2 healthcare facilities, and they were carrying the BLA KPC2 genes, which in New York, we see a lot of that. In Maine, it was very uncommon. And so they had a number of patients, and I'm not sure if you can see the details here, but there were a couple of clinical cases at 2 different facilities, 2 different organisms for KPC2 positive. We did some colonization screenings, we tested some additional samples, and we're able to use the MinION nanopore sequencing to help us understand that it appeared to be the same plasmid in all of these cases. We can't definitively say the transfer happened, but we're able to understand the epidemiology, the patients that were in the same rooms together, and analyze these different plasmids and the chromosomes from the different species and make that decision. The third example I wanted to tell you about is that we had a long outbreak over some time that involved 28 patients over 6 months. There were 28 carbapenem-resistant KPC-positive isolates that we had. We did both the short-read whole genome sequencing to determine the gene variants as well as relatedness among those cases. And we used the nanopore sequencing to help us understand about the different plasmids. There was a shared KPC3 plasmid in one cluster, but there were a number of different clusters. And it was very interesting to kind of see the differences between these plasmids and really try to dive into understanding the dynamics of this investigation. So we were also able to publish that work, and please check that out if you're interested. Another very interesting opportunity we had was there's been very few cases of vancomycin-resistant Staph aureus in the United States. I think it's up to maybe 16. We had the third case in 2004 in New York, and it was a sad situation, but it was a long-term care resident who had MRSA infection over a 6-month period before she passed away. And we were able to, over this time period, collect a number of isolates from this individual that we had stored away. We had originally done a lot of work, but we didn't have whole genome sequencing and certainly not long-read nanopore sequencing. So we recently went back and we looked at 11 MRSA strains, 3 VRE strains that contain the VAN-A gene, and 4 methicillin-resistant Staph aureus strains, all from the same patient, to just try to understand a little bit more about this. We used, like I said, the different types of sequencing and analysis, and we were able to definitively show, which makes perfect sense, that it does look like the VAN-A gene was the donor from that VRE isolate into the MRSA that created the VRSA strain, but the VRSA strain persisted over time, and we were able to show also that it integrated into the chromosome. So it was very interesting to look at all that, look at the dynamics of this situation in an individual as a unique opportunity, and we also were able to publish that work that describes what we think is maybe the first indication of the VAN-A plasmid, the VAN-A gene, moving into a chromosome. Okay, moving on. So a lot of AR work that we're doing. We're trying to answer a lot of questions about transmission and novel antimicrobial resistance, but an important role we play is the bacterial reference testing for the state, and we receive about 500 to 1,000 isolates each year to determine bacterial species for clinical reporting. And we've done about 20 years of Sanger sequencing with that 500 base pair region, some full genome sequencing. We've utilized a couple of databases to do that work as well as we can. A lot of work for our staff, manual trimming, assessment of chromatographs, resequencing in a number of cases. We use a core facility, so it takes us a good amount of time to be able to get those out. But it's about $10 a sample, so that's pretty good. But we only have about 50 to 70% successful species-level identification. So we, a few years ago, and this was under the direction of Kara Mitchell, who's here with me today, we're able to bring Nanopore 16S sequencing on to really see if we can examine, make some gains in our testing. And this would be full gene sequencing. We made some major improvements in our testing. I'm not going to tell you a ton about it today, but there's now we can report at about 93% of those analysis that we do. We've reduced a lot of that staff time, reduction in our repeat testing, and those that are able to completely unable to ID. We now also have some potential to resolve mixed isolates that we may receive, and we're seeing an improvement in the turnaround time. It costs a little bit more, but it seems to be worth it, and it's really exciting for the future to be able to do more of this testing, and we're really hoping to move that to primary specimen testing soon. Okay, now moving on to TB, Mycobacterium tuberculosis. So we're very excited about being able to do direct specimen sequencing to have an impact on cases of tuberculosis. So as most of you know, TB is one of the world's deadliest diseases. We have the third largest number of cases in the US and New York, and a lot of them, maybe 20% or so, have some sort of drug resistance. And we are seeing big increases this year in the number of submissions, as well as the amount of drug resistance related to the pandemic and the closing of some of the clinics. There's a lot that we're still unfolding. And there's quite a few new treatments and drugs available, which is exciting for the TB community and those that work on treatment and detection. And when we do have a highly resistant tuberculosis case, it can cost between $500,000 to $800,000 to treat an individual. It's a really big impact on a county health department, a state, local health departments to be able to observe and get the right treatment in place really quickly and to really hopefully cure that person. And I think probably most of you know it's a great case to use rapid methods because culture can take weeks and full susceptibility panels can sometimes take months. So to wait that long to get somebody on the right treatment is a long time. So again, a big group of people who have worked on this. I'm so thankful for all their contributions. And Shannon Murphy, who's shown in the picture on your left, was here in New York City for the Nanopore community meeting last year. And we've made some gains since that time. And so we now have a clinical test in place. So we developed and validated this assay. We're doing automated extraction with the EZ1. We have a multiplex PCR with 2 tubes, 13 targets, and 9 antimicrobials assessed, which fits nicely with what we're trying to do at the moment. We're still going to do a whole genome sequencing on every isolate of TB, but this will be our first pass. We're so excited to be using the gridiron and some of the new improvements with flow cells and base calling. We're very excited. We can do that sequencing in less than 2 hours. We're also reusing those flow cells 3 to 4 times, which has been great. And we have some in-house developed pipelines. So Pascal Lapierre developed our whole genome pipeline, and he's also developed this pipeline that they work together so we can kind of look at the same things in New York. This test offers more information than another test we've also used over the years, pyrosequencing, short-read sequencing from those primary specimens, but that was limited to a few different drugs and targets. And so far, our results are really nicely concordant with our whole genome sequencing analysis. And just a little bit more in terms of what that assay looks like. And we started this before there were some commercially available assays, so we're very excited to compare and contrast with those as well. But in terms of our assay, you can see on the far right the pyrosequencing we were doing previously. We still are doing it a little bit longer, but smaller sizes for those amplicons, only those 3 different drugs assessed. And you can see the targets and the size of the amplicons we're looking at and the improvement in the amount of the genome we're interrogating in a sequencing assay like this. And so now we're getting those primary specimens, a lot of sputums, respiratory specimens, and we're doing an initial real-time PCR to make sure it is TB, and it's in good enough quantity to move on to the next test. And we're doing direct targeted next generation sequencing very quickly. We also have a number of samples we receive where the culture has TB mixed with Mycobacterium avium complex, and so those in the past we've had to send back to the submitting lab, have them reculture and submit. That's led to a lot of delays. Now those mixed samples with the special request can go on for this targeted NGS assay, saving a lot of time in those determinations. And like I said, we're still doing our whole genome sequencing and phenotypic DST when we find predictors of resistance. And I mentioned we went clinical with this in April of 2023. Right around that time, we had a very interesting case. As an example, we had a 32-week pregnant woman who had a rifampin-resistant MTBC positive taste with the Cepheid kit. And so in many cases like that, we're asked to confirm that. Can we confirm that quickly to help them decide on treatment? So we received the sample at Wadsworth Center. And as the title alludes to, we detected an extensively drug-resistant XDR TB in this case. But we received it on day 0. On day 1, we did our PCR. We knew this was TB. And on day 5, we had a targeted NGS nanopore sequencing result where we could predict rifampin, isoniazid, ethambutol, streptomycin, injectable, and fluoroquinolone resistance. Highly resistant strain. We had a couple of targets that we couldn't report at that point, but this was a flag. This was an XDR, a really important case to be aware of. It was very helpful for the clinicians to decide about treatment of this case. They decided actually to wait until she had the baby, but I think she gave birth sooner. But in this case, we had that result on day 5. It wasn't until day 13 we had a culture. And on day 26, we had that whole genome sequencing available, and that was able to determine the pyrazinamide resistance as well as confirm all of the other results. And at day 84, we finally had some DST susceptibility test information, but because it was a very slow-growing bug, some of that DST never was successful. So having an assay like this on day 5, huge impact on treatment. And this was a milestone for us. First time we were able to detect a case like this directly from a primary sample. So just to sum up, in terms of comparing the work we're doing at the targeted NGS to our whole genome sequencing work, which is also critical for other reasons, for surveillance and understanding relatedness between cases, but we're seeing an average 15-day improvement for primary specimen testing, and we're seeing a large improvement for those contaminated cultures I mentioned that have both the TB and MAC included, so 43-day improvement. We have had cases where we've been able to do the Nanopore TNGS in less than 24 hours with our staffing and be able to prioritize and work out our timing, which has been really helpful in some additional cases. It's costing us about $75 a sample, which is also great and comparable to our whole genome sequencing testing, so we can do quite a bit for one patient with those costs that we're seeing. We were fortunate to publish this also last year. And so the future. So there's a lot of things we want to do. We're so excited. We have a project right now working on identification of non-tuberculous mycobacteria, which is often challenging and often requires 10 or 12 different tests, and sometimes is not successful. But we're working on a targeted panel of housekeeping genes that are listed here that maybe we can get a really good identification for those and be able to report these out really quickly and not have to do additional culture and mass spec and other sorts of work on these. We're also working on some direct detection methods for Legionella and STEC, E. coli, so water, stool, respiratory, and autopsy specimens where we want to get as much genomic information from the primary sample. We may not be able to culture in many of these cases, so we have some work for that. I'm going to show you a glimpse of that right after this slide, and that we're continuing to optimize, validate, and revalidate our MTB TNGS assay and our 16S assays. There's been so many great improvements, but it leads us to have to do a number of validations to kind of keep up, so we're in the middle of that at the moment. I already said moving the 16S to primary specimens, which is a goal. and that we do want to look at whether we can kind of switch to using nanopore sequencing for our whole genome sequencing as well as for our targeted needs, and that will be something we investigate. We're going to do some additional wastewater work and possibly work on an AR plasmid database for the Northeast. And then just finally, this is just some work we've been working on that we've submitted a paper hoping to be published on this, but we're using a way to bait for clinical specimens where we can't culture the Legionella. If we just do direct sequencing either with Illumina or Nanopore, it's hard to see, but there are no Legionella reads detectable. And we've developed a hybridization capture RNA baiting method that if we utilize it in the right way, we can really increase the reads for analysis. And you can see 23, 24% from the undetectable, which is allowing us to do some genomic comparisons for the sources or other patients associated with those investigations. So we're very excited about that. And with that, I'm going to end. Here's a picture of our bioinformatic team in bacterial diseases. We have a core facility which has been fantastic at doing a lot of the work for us on the Illumina side. We have a bioinformatics core. We have a lot of funding through CDC related to ELC and AMD supplements, and really want to thank O&T for all of the work and support with our user group. We've been really, really fortunate. So thank you very much. I will end there.